Hello, hi everyone. Good morning, good evening, good afternoon, depending on which part of the world are you joining from. Today we are delighted to have a guest from Cameroon who is a rising star. He's being honored with Sabin's Rising Star Award for vaccine equity because he's demonstrated it is possible to identify zero dose children and reach them. And it's my pleasure to have this conversation with Dr. Clovis and welcome him here in Sabin Studio. Welcome, Dr. Clovis.
Thank you so much, Anuradha.
So it's great to have you with us because at Sabin, we are very interested in understanding the perspective and the point of view and the experiences of immunization professionals who are working on the ground to make things happen. So, Dr. Clovis, the first thing that I really want to understand is how did you start to believe in this whole concept of zero dose children, something that I am very passionate about, having created this concept, and what exactly did you do in order to identify and reach these zero dose children who had been missing the most essential life-saving immunizations for God knows how long?
Wow, that's a very interesting question. Actually, it's been not just a one-time thing, that happened and I understood that, okay, zero dose children should be a priority. It's just a series of so many events. For instance, you move into a community and you realize that the women give birth at home, which means the children technically miss out on, the first doses of vaccines, which of course, as we all know, when a child has access to the first dose, there's an increased chance that they can have access to the other doses. So at that time, the concept of zero dose was not known per se. So what I knew was these children were unimmunized and that was it. But in 2019, Clinton Health Access Initiative did an interesting survey across 6 districts. And just in those 6 districts, we had over 1,000 unimmunized children, right? So at this time, we're still not calling it zero dose at all, but we knew that there were over 1,000 children in such a few communities that, were unvaccinated. And this was inspiring because it meant that probably in other regions, there are these kind of communities that have clusters of zero dose children, which we have been missing all along, and these communities miss out not just on vaccination, but also on other primary healthcare services. So if you were to find out a community where maybe 40% of women give birth at home, then you are most likely to have, clusters of zero dose children. So that was just how it all progressed to this stage.
Wonderful. So you actually said a couple of things which are so important for everybody to remember. One is that with the unvaccinated children, which we now call zero dose children, or under vaccinated children, they actually remain very powerful symbols of gaps in immunization. But more importantly, they represent those families and households that are deprived of several other health services. For example, the mothers of these children often do not have access to skilled birth attendants, as you said, and therefore end up delivering at home, which really means that women in those households are bereft of essential services, and then the children also at much higher risk of not receiving immunization, but also other services. So, Dr. Clovis, tell us, what did you do exactly to make sure that these children received their vaccination and that these households and families actually had much stronger health-seeking behavior?
We realized one thing. These communities, they know what vaccines are. They would have loved to have vaccines, but they have other issues that turn to, serve as a barrier, between their children actually having access to these vaccines. And the most common is maybe you go to a community where, there's a lot of malaria cases and malnutrition. So that is their priority. Now, when you move into this community and the first thing you're offering is vaccines, they will resist, because the impression is, if we cannot have access to food, we cannot have access to other things, and you are bringing us vaccines, then there is something wrong with the vaccines. So that trust gets eroded. So what happens is, when we approach this community from the perspective of, oh, we are coming to help them, or we are coming to solve their problem with vaccines, it just doesn't work. So to make this work, we started off by setting up what we called a micro facility. And that micro facility was to offer a basic health package that constituted what the community considers as their priority. So when this was done, it became easier now for, the population to gradually warm up, to vaccination services, because they could now ask, because they know that, okay, when I go to this facility, if my child is sick, they are going to take care of my child. And then they become even closer to, the healthcare worker. The other approach, which I found very interesting, had to do with the use of community-oriented primary care model, in which you go to a community where there is no health facility, but they have community health workers, and where they don't have, you build one with the community. And then you use this model to sample opinions and understand which health needs that community really needs. And then you put up a package that suits community health workers. And then through that, community health workers, while offering these packages, are able to refer patients for vaccination. So these kind of integrated approaches have proven to really work quite well. And that's mostly what we do.
So this is very insightful, Dr. Clovis, because one of the very important aspects of Sabin's new Brave and Bold strategy is the E in Brave. And that E is all about enhancing integration, because we acknowledge that unless we provide an integrated package of services to communities most in need of healthcare, there just won't be any acceptance of standalone interventions. So you really echoed that by saying that when only vaccines are taken to these communities, which have multiple other healthcare needs, which from their perspective might at times be even more vital, then not paying attention to those needs and continuing to follow a health intervention like vaccination in isolation can actually be counterproductive. And therefore, understanding communities' felt needs and trying to provide an integrated healthcare package is really the best way forward, because it is then useful for vaccination, but it's really useful for communities, because it is then an opportunity to respond to their needs much more holistically. me ask you another related question, and that is about HPV vaccine. You spoke about mistrust or lack of trust on the part of communities and making sure that we offer a broader package of services to communities to really establish that trust between health institutions and people. What about human papillomavirus vaccine? Cameroon is one of those countries that introduced the vaccine in their public health program, and yet coverage of this vaccine has been quite low. What do you think are the drivers of this low uptake of a vaccine which is highly effective?
What is critical about vaccines?
All the questions are appropriately addressed. And finally, this whole value of making a connection with education. And I think that's often forgotten, because this is the first time probably that vaccination community is having to go out and really forge a big time collaboration with education and teachers. And we have seen in many countries that at the time of introduction, that connection is made, but it is soon forgotten. And that is why sustaining HPV vaccine is becoming a big challenge. So a very good reminder of the need for that engagement between health, vaccination, health, and education. You also touched very briefly on out-of-school girls. So would you be able to share with our audience some of your insights about how do we address the vaccination of out-of-school girls? Because in some countries and in some communities, the population of out-of-school girls can be substantial.
With out-of-school girls, I think where we lack has to do with qualitative data. Because what happens is we focus too much on the quantitative data, how many girls are here, how many did this, and so on, that we end up forgetting to characterize the girls we are talking about. Which children exactly are we talking about? It is only when we match quantitative data that gives, that quantifies and locates or maps where these children are. And then the next step to characterize them, not just by knowing that they don't go to school, but understanding what exactly are they doing at home first. What are the situations surrounding their being at home? What do they do when they're at home? What do the parents think? Because for a girl child that is in school, they may hear about HPV vaccine, but for a child that is at home, it's different. So when the child is at home, where exactly do they go to? So for me, I think the first step to vaccinate children that are out of school is to first do a study. Mm-hmm. Countries should take the initiative, divide their countries into zones based on socioeconomic factors, do small samples, go into those communities, observe, live with them, be with them a month, 2 months, collect good qualitative data, interview. For a second, pretend to know nothing. Just talk with caregivers, the community, mothers, understand perspective. They will give important insights on how to get these children vaccinated. Some of these children belong to a group of girls mentored by elderly women, grandmas, and so on. Without qualitative data, we will never know this kind of information. And the interesting part is there will hardly be one approach to solving this issue. But with this kind of qualitative data, one is able to decide and say, okay, for instance, in Cameroon, the differences are just too wide. You know that, okay, in the northern region, they are more conservative, they are mostly in the house and so on. It means that if I go to vaccinate on these days, I will likely find them and so on. So there's this variation that cuts across different regions in different countries. If we start from there, public health experts will be able to design context-specific approaches that can catch up with these children.
So I think a lot of us continue to say one-size-fits-all approach doesn't work. It shouldn't be prescribed from top or from global level, but I think you have so beautifully explained what a contextual intervention would look like, because it does require a lot of upfront investment in really understanding, but through a sample study, what is it that communities want for any kind of intervention to succeed. And I think I also don't want to lose the point that you earlier made about storytelling. How do we equip everybody to tell a story in a way that touches the hearts of people and actually wins their minds. So both hearts and minds, and so that they come along with us on this public health and vaccination journey. Thank you, Dr. Clovis, for those wonderful insights. It was truly a pleasure talking to you.
The pleasure was all mine. Thank you very much.
Thank you.